All right, we are going to talk about a really important concept today called the Osmole Gap. You probably have seen it in practice questions, and maybe you understand it, maybe you don't. My job is to try to teach you the understanding of the why behind this, so you can not only answer your questions on the USMLE right, but also use this in real life. I've actually used it in real life multiple times now. It's an important calculation and a concept to understand. So let's get into it. So we're going to talk about what is the osmole gap, how do we calculate it, what are the three major causes of the elevated osmole gap, and kind of what points me into the direction of each one. What's the treatment? We're going to talk briefly about anion gap versus non-anion gap metabolic acidosis, and then we'll put it all together. So this was a question I posed Instagram this morning. If you didn't get a chance to answer it, here's your chance now. So we've got a 42-year-old man is brought to the emergency department after being found unconscious at home next to an empty bottle of antifreeze. On exam, he's obtunded. Lab values are as follows. The sodium's 138, the glucose is 100, the BUN is 12, the measured serum osmolality is 312. Which of the following is the patient's osmole gap? We've got 10, 18, 22, and 26. So you can pause your screen and think about it, and I'll move on. So this patient's osmole gap is going to be 26. Now, to be clear, on your USMLE exam, they will never ask you like a question straight up like this, where there will be 4 or 5 options of just numbers where you would have had to calculate the osmole gap. But there will be questions where they're going to expect you to know how to calculate the osmole gap in order to dictate what the next best step in patient care would be. Obviously, we would use this in real life too. It's just, this was me kind of like reverse engineering the question to see, can you guys actually calculate the osmole gap and see where we were starting? And based on the Instagram poll, this is a topic that needed to be covered because a lot of people did not get it. So let's talk about what this osmole gap is so we can further understand our reasoning of this question. So the osmole gap is the difference between the measured and calculated serum osmolality. If you watch my hyponatremia lecture, if you haven't, go watch it. But I talk all about the difference between osmolality and tonicity. That's not the point of today's lecture, so go watch that. But remember, we can calculate the serum osmolality using the formula 2 times sodium plus glucose divided by 18 plus BUN divided by 2.8. And if they give me the patient's serum ethanol, we take ethanol divided by 4.6 and we add that on. Classically, you're not going to get that ethanol, okay? So what happens is the lab, when I take the patient's blood and I send it to the lab can calculate the osmolality. We saw that on this case, right? 312, the lab calculated that. I can then run that equation that I just said, 2 times sodium plus glucose divided by 18 plus BUN divided by 2.8. And the lab can get a number and I can get a number. And if those numbers are different, right, I take the highest number, right, the lab number usually, minus my number that I calculated. And if that number is greater than 10, it suggests the presence of unmeasured osmoles that are classically seen in toxic alcohol ingestion, okay? The classic ones that are actually going to have like clinical importance are really going to be methanol and ethylene glycol. I'm also going to briefly talk about isopropanol, okay? There are a few other causes like mannitol and glycine can cause a elevated osmole gap. They're not really clinically relevant. They're also like, I could look at the patient's drug list, right? If they have mannitol or glycines used in urological procedures sometimes, we could kind of tease that out. But really, for the sake of USMLE and for the sake of like real life, this is a life or death situation. We need to figure this out. I'm thinking about my 3 toxic alcohols. The 2 major ones are ethylene glycol and methanol. And then the third one will be isopropanol. And we're going to talk about these in a second. So I really just wanted to flesh out a bit. Why can't the lab measure these osmoles directly? Or like, what's going on here? Why do I get this gap? Well, when I send the blood to the lab, the routine lab osmolality measurement, it captures all the solutes in the serum, both the measured and the unmeasured, okay? It can't tell me what it is, what this unmeasured is, but it will calculate every solute in the blood, okay? When I calculate the osmolality, I'm only taking into account sodium, glucose, BUN, and if I have it, the ethanol, right? So when I calculate the osmolality, I'm missing this unmeasured osmole if it's present in the system. The lab is able to pick up on it, okay? So if the lab picks up on it, and me as a smart medical student or the smart attending physician one day, right? If we're able to calculate the serum osmolality and we say, hey, there's a difference of greater than 10 in what I calculated and what the lab did, we should think about one of these toxic alcohol ingestions, right? So the unmeasured osmoles are not part of the standard chemistry. So like, unless we order it directly, like tell the lab, hey, we want you to get an ethylene glycol level on this patient, they're not going to order it. They're just going to tell you their straight up serum osmolality. Okay. So again, we take the lab's measured osmolality, we take our calculated osmolality. If that difference is greater than 10, we're thinking about a toxic alcohol ingestion. Okay. The lab can pick up on those unmeasured osmoles. My calculation cannot because it's only accounting for sodium, glucose, BUN. All right. So to like look at our case, right? Here's the formula I told you. So if you've never heard about this formula before, or you're like, what the heck? Screenshot it, put it onto an Anki card, do it for a week. You'll have it memorized for the rest of your life. Very important equation. There aren't many equations I tell my students to know. This is one of them. So if we plugged in our values and we plug and chug, right, we'll get a value of about 286. Okay. In the stem I gave you, the serum osmolality that the lab calculated was 312. If I do 312 divided by 286, it gets me about 26, our right answer, okay? I told you the literature is telling us if the osmole gap is greater than 10, we should start considering toxic alcohol ingestion. I included a DOI for a New England Journal Medicine article that's great about toxic alcohol ingestions and everything about it. Screenshot it, throw it into Google, and read for yourself. It's a beautiful article. All right. So I wanted to talk about the three major toxic alcohols, right? This is, if you're going to know one slide, right, I would know the equation I just talked about, and then this slide, right? This is going to get you your points on your exam and save a patient's life in real life. So we've got methanol. When I think about methanol ingestion, right, we've got the elevated osmole gap, and then I'm going to look for visual changes, blindness, and confusion. The reason is methanol is broken down into formic acid, and formic acid can cause optic nerve damage. This formic acid will lead to a anion gap metabolic acidosis, and then we're going to use fomepizole and dialysis to treat the patient, right? When ethylene glycol, again, we've got an elevated osmole gap. This patient might have flank pain, hematuria, hypocalcemia, fruity breath. This is because ethylene glycol gets broken down into oxalic acid. Oxalic acid can cause renal failure and it can cause calcium oxalate stones. That oxalic acid is going to lead to an anion gap metabolic acidosis. Again, hey, treat it with fomepizole dialysis. Isopropanol can cause fruity breath, CNS depression, but it's not going to cause acidosis because isopropanol is broken down into acetone. Acetone is a non-acidic metabolite, so there's no anion gap metabolic acidosis, and we really just use supportive care. So again, that's why I was saying at the beginning, right? If I see this elevated osmole gap and an anion gap metabolic acidosis, I honestly, at this point, do not care if it's methanol or ethylene glycol poisoning. We can figure that out later. Let's get this patient some fomepizole ASAP, okay, and treat them and potentially put them on dialysis. And then we can tease out, okay, are they having more visual symptoms or are they having more kidney type symptoms? And we can look at the patient history too. Methanol, you'll classically see like a history of like moonshine, or the patient was trying to make their own like alcohol beverage of some sort. And ethylene glycol is classically like antifreeze, okay? Again, and if it's isopropanol, they will have the elevated osmole gap, but you'll calculate the anion gap that I'm going to teach you in a second, and their anion gap's not going to be elevated. And that's when you're like, oh, it's isopropanol. All right. Hopefully that makes sense. And I will show you, we'll keep breaking it down further. So this is like beautiful pictures that will kind of like, if you're more of a visual learner. So we take ethylene glycol, we throw it through this alcohol dehydrogenase, and then we end up making oxalic acetate or oxalic acid. If I use fomepizole, or if we're in a pinch, I've seen this on questions too. The lab or the hospital, like it's a rural hospital, they don't have access to fomepizole. What do? We give them ethanol, because both fomepizole and ethanol will competitively inhibit alcohol dehydrogenase. It'll lead to a buildup of the ethylene glycol, but it won't make the oxalic acid, right? Because there's now an obstruction right at the level of alcohol dehydrogenase, so we can no longer make the oxalic acid that's causing all the problems. Same thing with methanol. We run through the same exact pathway and we end up making formic acid. Fomepizole and ethanol both inhibit alcohol dehydrogenase. We can no longer make the toxic formic acid that will damage the optic nerve. So again, your classic questions on actually, honestly, it could be a step 1 or a step 2. For step 2, they're probably going to ask you, how do you treat it, right? Fomepizole, 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 or ethanol if they're going to try to be cute with it, right? For step 1, they might ask you more about the enzyme involved, alcohol dehydrogenase for both of them. All right. So let's talk about anion gap acidosis really quick. What is anion gap acidosis? It's caused by a accumulation of acids with unmeasured anions, which replace the bicarb. So remember where our body is trying to stay in electrical neutrality between negative charge and positively charged. When I lose a negative charge, we need to replace that negative charge. The two major things that are negatively charged in my body are going to be chloride and bicarb, right? And then all of these anions are like the third step, right? But chloride and bicarb are they're inextricably they're linked. They're linked perfectly in our body. We have all these chloride bicarb exchangers throughout our body. So when I lose bicarb, your kidney is going to try to hold on to chloride. When I lose chloride, we're going to try to hold on to bicarb and vice versa. Okay? What happens is when we get these unmeasured anions, your body's like, yo, my negative charge is way out of whack, right? We need to remove some of this excess negative charge, and your body chooses to get rid of bicarb. Okay, so we get rid of bicarb because of all these unmeasured anions, and it now puts us into a metabolic acidosis with a high anion gap. Okay, so hopefully that makes sense. For the non-anion gap metabolic acidosis, these are due to loss of bicarb or an inability to excrete hydrogen. But instead, the chloride is going to increase to compensate. So in this case, let's say your patient has diarrhea. In diarrhea, we classically lose bicarb via the diarrhea. We're losing the diarrhea. Your kidney is going to sense that. And because there's no excess unmeasured anions, your body is basically sensing, hey, my negative charge is going down because I'm losing this bicarb. Kidneys hold on to this chloride, right? And the chloride will start to rise, and we'll get a hyperchloremic metabolic acidosis, okay? That's because we're able to appropriately compensate with the reabsorption of chloride because we don't have these unmeasured anions that are throwing off my neutrality. We're losing bicarb, our body's able to hold on to the chloride. In the sense of anion gap metabolic acidosis, well, now we have these unmeasured anions that's throwing everything off. We're going to remove our bicarb, but we're not able to touch our chloride as much. We're not able to raise our chloride as much because of these unmeasured anions. If I were to raise the chloride too much, it would make my negative charges way higher than my positive charge, and that would throw us off as well. All right. To calculate the anion gap, it's our classic equation. Sodium minus the combo of bicarb plus chloride. If that's greater than 12, that's an elevated anion gap. You need to know that cold for USMLE step 1 and step 2. Honestly, if you don't know it at this point, if you're going into USMLE step 2, I think you have bigger fish to fry. So throw this onto an Anki card too, and have that ready to rock and roll. All right. Causes of metabolic acidosis, you may have remembered mud piles. Mud piles is long gone. If you're still using that, get with the times. Come on, let's go. So for the new mnemonic is Goldmark. And Goldmark, so the G stands for glycols like ethylene and propylene. Your O is oxoproline, so that's a metabolite of acetaminophen. Your L stands for L-lactate, so that's an ischemia or sepsis, or we've got hypoperfusion to some area of the body. We're increasing lactate production via anaerobic metabolism. The D-lactate is seen oftentimes in like SIBO. So a patient who has terminal ileum damage, or we have a closed loop bowel, it allows my bacteria to just set up shop in that closed loop. Those bacteria chomp on your carbohydrates. They release a lot of D-lactate, and that can lead to a anion gap metabolic acidosis. The M is our good friend methanol that we've talked all about. So remember, the formic acid will hurt the optic nerve. The A is our aspirin. So remember, aspirin is converted into salicylate. Salicylates can cause metabolic acidosis due to disruption of my electron transport chain. Renal insufficiency, right? Our classic uremia that gets super high. And then ketoacidosis, alcoholic, diabetic, and starvation. All right. So all things you want to consider when you see a patient with anion gap metabolic acidosis. Non-anion gap metabolic acidosis, I really highlighted in red the two big ones that I want you to know. So GI losses, I already told you. When the patient has diarrhea, we're losing bicarb through the poop. When the patient is vomiting, right, it's kind of the opposite. Think about all my stomach acid, HCl. We're going to lose more HCl than we are bicarb, right? So going out the bottom is bicarb. Going out the top is HCl, okay? The other one that I really want you to know, whenever you see a patient who's like hospitalized and they're getting fluids and they have a non-anion gap metabolic acidosis, this is probably why. I went into detail on this in one of my other lectures on why 0.9% normal saline can cause a non-anion gap metabolic acidosis. I'll repeat it again because I think it's worth repeating. when I think about my sodium chloride load in 0.9% normal saline, it's 154 millimoles of sodium and chloride. What is my normal extracellular amount of sodium? Well, it's about 140-ish, right? 135 to 145. What's my normal chloride? About 100, right? So when I give 154 millimoles of sodium chloride, sodium is about the same, right? 140, 154, maybe a little bit more, not too much, right? But when I think about chloride, right, 100 to 154, man, that's a major gap. My body is now sensing this huge increase in negative charge. And what did I tell you is going to happen? When my negative charge goes up in one anion, the other one needs to be compensated and gotten rid of, right? So when my body senses this massive chloride load via 0.9% normal saline, the kidneys are going to cause the excretion of bicarb through the urine. So the chloride load has gone up, 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 and we pee out the bicarb. It puts us into a non-anion gap metabolic acidosis. It's a hyperchloremic metabolic acidosis. I'm sure at some point you memorized the stupid Anki card where you're like, normal saline can cause hyperchloremic metabolic acidosis, and you probably just stopped at that. Now you understand the why, and you'll never forget it, right? There are other like lower yield causes like renal tubular acidosis. Type 1 would be impaired hydrogen secretion. Type 2 would be impaired bicarb reabsorption. And type 4 would be low aldosterone, so we get decreased ammonium excretion. And then there's early renal failure and urethral diversions. Really, for the sake of USMLE step 1 and 2, and for like real life, I would really focus on GI bicarbonate losses, excess chloride, and then if you want to go the next step, we can start to learn about renal tubular acidoses. That can be its own lecture on itself because they're quite complex. If you want to read a little bit more about non-anion gap, there's an article for you. Screenshot that. So let's put it all together. So we have a 34-year-old man is brought to the emergency department by his roommate who found him confused and vomiting. The roommate reports that the patient had been drinking heavily the night before and may have ingested some kind of garage antifreeze. On exam, the patient is lethargic and tachypnic and mildly hypotensive. Lab studies are as follows. His blood pH is 7.12. His PCO2 is 20. His urinalysis, there's blood positive. The RBCs are 0 out of 2 or 0 to 2. Crystalluria is present. He started on fomepizole and IV fluids. 2 days later, he passes a kidney stone. Which of the following best describes the microscopic appearance of the stone passed by the patient? Was the stone going to be hexagonal? Is it going to be coffin-libbed? Is it going to be needle-shaped? Or is it going to be envelope/dumbbell shaped? So take a second, look at the labs. I want you to try, right, when I get a patient like this, whenever, I'll give you like a high-yield tip too. Whenever USMLE gives me the serum osmolality, you better believe I'm always calculating my osmolality to see if they're hinting at an Osmole gap. Whenever I get labs like this, and I'm also kind of leaning towards like acid-base balance, right? I always calculate anion gap first, right? I'm going to do a whole lecture on acid-base analysis, but the first thing I always do, I calculate the anion gap, then I calculate the delta gap, then I calculate the corrected bicarb, I find out the primary disturbance, and then I find out the compensation. And if that means absolutely nothing to you, that's okay, because I'm going to go through it on an acid-base lecture later on. So I want you to approach this problem like you would on an exam and tell me which type of kidney stone you'd see. So pause your screen. So these are going to be calcium oxalate stones, right? And if you remember back from step 1 land, we're going to see D. It's going to be envelope or dumbbell shaped crystals. And honestly, like you might think of this as like a step 1, but you better believe step 2 is moving more towards like a pathophysiology type exam. And there's a lot of questions like this, okay? Where they're getting more at the osmolality. So, or more, sorry, more at the pathophysiology of things rather than just the next best step diagnosis. So we need to understand pathophys and what's going on. So first things first, we calculate the osmolality. In this case, it's 292. We calculate the Osmole gap. I gave you the calculated osmolality. So we do 360 minus 292. That's 68, way above 10. So we're good to go. We need to figure out which toxic alcohol was this ethylene glycol, methanol, or isopropanol. Well, I can get rid of one right off the bat because if I do my anion gap, sodium minus bicarb plus chloride, that gives me 140 minus 110. That's 30. That's way above 12, right? So it must be either ethylene glycol or methanol. If I look at the history, right, we see antifreeze and we see kidney stones. That points me more in the direction of ethylene glycol. And then remember that ethylene glycol gets broken down in oxalic acid. that makes calcium oxalate stones. Now, you could have done all this and still gotten the question wrong, which really sucks, right? That's just the nature of some of this. We need to then do the final nail in the coffin, and we need to say, okay, remember, calcium oxalate stones, they look like envelopes or dumbbells, right? Hexagonal are going to be cysteine, coffin lid are going to be struvite, needle shaped are going to be uric acid. I will go back because I've mentioned this in like previous lectures too. Whenever I see blood positive, but the RBCs are very, very minimal, I really think of two things. I think of myoglobinuria and hemoglobinuria. Okay, in this case, he's probably got myoglobinuria. He honestly could have some hemoglobinuria. But when I hear his case, he was vomiting, confused. I probably think of like some sort of muscle necrosis or some sort of breakdown of a lot of cells. So whenever I see the urine dipstick will pick up heme, myoglobin, and red blood cells as blood positive. But then I do the more advanced UA, and the more advanced UA is able to tell me how many red blood cells per high-powered field. When it's hemoglobinuria or myoglobinuria, that those aren't actual red blood cells. The heme is a part of a red blood cell, and the myoglobin is coming from muscle cells, but they're not actual red blood cells. So you're going to see the blood is positive on the dipstick because it was picking up the heme or the myoglobin, but the actual red blood cells are very, very minimal. So when I see that, I think about either hemoglobinuria or myoglobinuria. If the blood is positive and there's a lot of red blood cells in the blood, now I'm like, all right, this is true hematuria. Really didn't matter to answer this question. I've asked it on questions before where it matters. It's just something for you to think about. All right, so in this case, in this lecture, we went through the Osmole Gap, how to calculate it, the three major causes, what points me in the direction here or there. Remember, the treatment for ethylene glycol and methanol are absolutely going to be fomepizole and then dialysis. Isopropanol, we really don't need to do much unless it's really severe. Remember, the way we can kind of tell them apart right off the bat, we do the Osmole Gap. The Osmole Gap's elevated in all three of them. Only methanol and ethylene glycol are going to have an elevated anion gap due to formic acid and oxalic acid. Isopropanol gets broken down into acetone, which is not an acidic metabolite. So if I calculate the Osmole Gap, it's elevated. It's above 10. If I calculate the anion gap and it's normal, okay, this is isopropanol. If the anion gap is elevated, okay, it's ethylene glycol, it's methanol. Then I look, okay, does the patient have retinal damage? Are they having vision disturbances? Were they just making their own alcohol, right? Methanol. Were they drinking antifreeze? Were they found passed out in the garage, right? Do they have kidney stones? Do they have kidney pain? Do they have a fruity breath, right? Do they tell me something about calcium oxalate stones, ethylene glycol? If they're asking me about the treatment, this is like a major point for any step question. If the question is asking me, what is the most likely diagnosis? Then I need to do these mental gymnastics. Then I need to think about, okay, is this methanol, ethylene glycol, isopropanol? If they're just asking me what's the next step in management, I don't need to think as hard, right? If I can recognize this as toxic alcohol ingestion, I know it's now ingrained into my head. Muscle memory, fomepizole, right? I don't need to think about which one it is. Don't waste time. Don't waste mental energy. Step 2 is a 9-hour exam. If you're wasting mental energy where it doesn't need to be used, you're just setting yourself up for failure as you get to blocks like 7, 8, right? So think about it like that. If this lecture helped you, like, let me know. If you got other topics that you want covered, please let me know as well. I'm here to help you guys. Keep rocking on.